Friends, today we will learn about immunodeficiency diseases. Here we will learn about primary immunodeficiencies. Under this we will discuss about humoral immunodeficiency, that is B cell defects, cellular immunodeficiencies, that T cell defects, and combined immunodeficiency, that is both B and T cell defects. Disorders of complement, disorders of phagocytosis. Then we'll study about secondary immunodeficiencies. Under this, we'll study about depression of humoral immune responses and depression of cell mediated immunity. So, let's begin. Immunodeficiency diseases are conditions where the defense mechanisms of the host are impaired, leading to repeated microbial infections and sometimes enhanced susceptibility to malignancies. Such defects may be primary or secondary. Primary immunodeficiencies result from abnormalities in the development of immune mechanisms. Secondary immunodeficiencies are due to malnutrition, drugs, and other processes mature immune system. These specific immune functions, humoral immunity, cell-mediated immunity, or both, or non-specific mechanisms such as phagocytosis and complement. Now let's know about primary immunodeficiencies. The defects may be T cell, B cell, or both, complement system, or phagocytes. Some primary immunodeficiency syndrome we will now discuss. It must be realized that there is considerably overlapping due to intimate interaction between the B cell and the T cell. For instance, the T cell deficiencies of helper or suppressor T cells will also have a profound effect on antibody response. Now let's know about humoral immunodeficiencies, that is B cell defects. Excellent A gamma globulinemia. We will discuss about this. This syndrome is the first immunodeficiency disease to have been recognized. It was first described by Bruton in 1952 and is also Bruton's disease. Is also called Bruton's disease. It is seen only in male infants. Manifestations are not apparent till about 6 months of age due to passive protection by maternal immunoglobulins. Patients suffer from recurrent infections with pathogenic bacteria, particularly with pneumococci, streptococci, meningococci, Pseudomonas, and Haemophilus influenza. The basic defect is a failure of pre-beta B cells to differentiate into mature B cells. All classes of immunoglobulins are grossly depleted in the serum. Tonsils and adenoids are atrophic. Lymph node reveals a depletion of cells of the bursa dependent areas. Plasma cells and germinal centers are absent even after stimulation with antigen. Affected individuals have a marked decrease in the proportion of B cells in circulation, but pre-beta cells are present in normal numbers in bone marrow. T cell functions are normal in these patients and can normally handle viral, fungal, protozoal diseases. Allograft rejection is normal and delayed hypersensitivity to tuberculin can be demonstrated. Treatment consists of routine injections of normal immunoglobulins. Now let's know about transition gamma globulinemia of infancy. This is due to an abnormal delay in the initiation of IgG synthesis in some infants. It may occur in infants of both sexes. Maternal IgG is slowly catabolized and reaches a very low level by the second month. Ordinarily, the infants start producing their own IgG by this age. When there is a delay, immunodeficiency occurs. Treatment with gamma globulin is not recommended in this condition as it may contribute to prolongation of immunodeficiency by negative feedback inhibition of IgG synthesis. Now let's know about common variable immunodeficiency. This is also known as late onset hypogammaglobulinemia because it usually manifests only by 15 to 35 years of age. It is characterized by recurrent pyogenic infections. This may also be associated with an increased incidence of autoimmune disease. B cells may be present in circulation in normal numbers, but they appear defective and are unable to differentiate into plasma cells and secretes immunoglobulins. Increased suppressor T cells and decreased helper T cell activity have been proposed as a cause of the disorder. In this condition, the total immunoglobulin level is usually less than 300 mg per 100 ml with IgG level less than 250 ml and 250 mg per 100 ml. Treatment is by administration of gamma globulin preparations intramuscularly or intradermally. Now let's know about selective immunoglobulin deficiencies. In these conditions, there occurs selective deficiency of one or more immunoglobulin classes, whereas the other immunoglobulin classes remain normal or elevated. Now let's know about selective IgA deficiencies. There is absence or near absence of serum and secretory IgA in this most common well-defined immunodeficiency disorder. These patients exhibit increased susceptibility to respiratory and gastrointestinal infections. Atopic disorder among IgA deficient individuals are high. Anti-IgA antibodies are present in many of these patients. Now let's know about selective IgM deficiencies. Selective IgM deficiency has been found to be associated with septicemia due to meningococci and other gamma negative bacteria. Now let's know about immunodeficiencies with hyper IgM. There is low level of IgA and IgG with elevated IgM. Some of these immunodeficiencies are X-linked and some inherited as autosomal recessive. Patients are vulnerable to infections and autoimmune disorders such as thrombocytopenia, neutropenia, and hemolytic anemia. Some patients develop malignant infiltration with IgM producing cells. Now let's know about transcobalamin 2 deficiencies. It is an autosomal recessive disorder. These individuals show metabolic effects of vitamin B12 deficiencies, including megaloblastic anemia and intestinal vilus atrophy. Immunologically, defects include plasma cells depletion, diminished immunoglobulin levels, and impaired phagocytosis. Treatment with vitamin B12 may restore hematopoietic, gastrointestinal, and B cell functions, but not phagocytic activity. Now, let's know about cellular immunodeficiencies, that is T cell defects. Abnormalities of T cell in development results in viral, intracellular bacteria, fungal, and protozoal infections rather than acute bacterial infections. Now, let's know about thymic hypoplasia, that is DGO, George syndrome. This is a developmental defect affecting the third and fourth pharyngeal pouches, which leads to aplasia or hypoplasia of the thymus and Parathyroid glands. T cells are deficient or absent in the circulation. The thymus dependent areas of spleen and lymph nodes are depleted of T lymphocytes. Delayed hypersensitivity and graft rejection are depressed. The humoral immune response is largely unaffected. Patients show enhanced susceptibility to viral, fungal, and bacterial infections. Most of these infants usually show other associated developmental abnormalities such as cardiac defects, particularly involving great vessels. Neonatal tetany, neonatal tetany is present. Transplantation of fetal thymus tissue has been reported to restore the immunological functions. Purine nucleoside phosphorylase deficiency, that is in short PNP. Inherited deficiency of enzyme PNP occurs due to a gene defect in chromosome 14 uh, which results in impaired metabolism of cytosine and inosine to purine. These patients show decreased T cell proliferation, leading to decreased cell mediated immunity and recurrent or chronic infections. Now let's know about combined immunodeficiency, that is both B and T cell defects. Under this we will study about circular immunodeficiency with abnormal immunoglobulin synthesis, and next is ataxia telangiectasia. So let's begin with Naegeli syndrome. There is depressed cell-mediated immunity associated with selectively elevated, decreased, or normal levels of immunoglobulin. Patients are susceptible to recurrent viral, fungal, bacterial, and protozoal diseases. The thymus is small and peripheral lymphoid tissues are hypoplastic. Autoimmune processes such as hemolytic anemia are common. Bone marrow transplantation, transfer factor, and thymus transplantation have been used for treatment with success in some cases. Adequate antimicrobial therapy is essential for the treatment of microbial infections. Now, let's know about ataxia telangiectasia. This is an autosomal recessive disorder where combined immunodeficiency is associated with cerebellar ataxia, telangiectasia, that is dilated capillaries, and ovarian dysgenesis and chromosomal abnormalities. Death occurs due to cynopulmonary infection early in life or malignancy in second or third decade. The majority of patients lack IgA and IgE, but some patients possess antibody to IgA. Cell-mediated immunity is also defective, which results in an impairment of delayed hypersensitivity and graft rejection. Transfer factor and fetal thymus transplants have been tried with limited benefits. Now let's know about Wascott-Aldrich syndrome. It is an X-linked recessive disease characterized by eczema, bleeding, and recurrent infections. Most of the affected children die due to complications such as bleeding, infection or lymphoreticular malignancy during childhood. The bleeding occurs due to thrombocytopenia, eczema from elevated IgE level, and recurrent infection from abnormalities in cell-mediated or thymic hypoplasia and antibody-mediated immunity. B cells are unable to respond to polysaccharide antigens. Treatment with transfer factor and bone marrow transplantation have been found to be beneficial. Now let's know about immunodeficiency with thymoma. This syndrome consists of a benign thymic tumor, impaired cell-mediated immunity, and agammaglobulinemia. It occurs usually in adults. Antibody formation is poor and progressive lymphopenia develops. Patients have been shown to have excessive suppressor T cell activity. Now let's know about severe combined immunodeficiency diseases. These include many syndromes with severe combined deficiency of both humoral and cell-mediated immunity. They are inhibited in the autosomal recessive mode. Many distinct patterns of this immunodeficiency have been till now described. Now let's know about Swiss type agammaglobulinemia. Such persons are born with lymphoid stem cells defects and lack both humoral and cell-mediated immunity. They have agammaglobulinemia and lymphocytopenia. The basic defect is presumed to be at the level of lymphoid stem cell. Now let's know about reticular dysgenesis. This is the most serious form of combined immunodeficiency. Here the defect is at the level of multipotent bone marrow stem cell. There is a total failure of myelopoiesis. The individual is born with lymphopenia, neutropenia, thrombocytopenia, anemia, and bone marrow aplasia. The condition is invariably fatal in the first week of life. Now let's know about adenosine deaminase deficiency, in short ADA. Adenosine deaminase, in short ADA, is an enzyme which catalyzes the conversion of adenosine to inosine in purine metabolic pathway. In these patients, ADA levels are low in the tissues, including red blood cells. The mechanism by which this deficiency causes immunological impairment is not clear. It is, however, believed that deficiency of ADA leads to accumulation of adenosine and deoxyadenosine triphosphate, which are toxic to lymphocytes, particularly T lymphocyte lineage. There is greater loss of T cell immunity than that of B cell. The T cell immunity than that of B cell. The immunodeficiency varies from complete absence of mild abnormalities of B and T cell functions. The infant with these severe immune disorders are vulnerable to all the forms of infections and most die during the first year of life. Now let's know about MHC class 2 deficiency. It is an autosomal hereditary recessive disorder in which failure to express MHC 2 molecule on the surface of antigen presenting cells, macrophages and B cells results in a deficiency of CD4 plus T cells. This is due to the fact that T cell, that is CD4 development, is dependent on the positive selection by MSC class 2 molecules in thymus. Thus, MSC2 deficient infants exhibit the deficiency of T cells, that is CD4 plus. This lack of these helper T cells results in deficient antibodies. Now let's know about disorders of complement component deficiencies. Genetic deficiencies of almost all complement components have been detected in man. Deficiency of C1R and C4 is associated with systemic lupus erythematosus. The most severe abnormalities of host defenses occur with CD3 deficiencies, with result in increased susceptibility to pyogenic infections. Deficiency of C6, C7, C8 is associated with Neisseria infections. The defects of all these complement components are transmitted as autosomal recessive traits, except that of properdin, which is X-linked recessive disease. Now let's know about complement inhibitor deficiencies. Hereditary angioneurotic edema is due to a genetic deficiency of C1 inhibitor, carbon 1 inhibitor, and this defect is transmitted as an autosomal dominant. Normally, C1 inhibitor is involved in inactivation of complement system and other pathways like clotting, fibrinolytic, and kinin. The C1 inhibitor deficiency, these systems may be activated. Activation of factor XII, that is Hageman factor, leads to formation of bradykinin and C2 kinin. These kinins act on the post-capillary venules, causing contraction of endothelial cells and formation of gaps that allow the plasma leakage and production of edema. Now let's know about disorders of phagocytosis. Phagocytosis may be impaired either by intrinsic or extrinsic defects. Intrinsic defects are within phagocytic cells such as enzyme deficiency, and extrinsic defects may be due to deficiency of opsonin antibody, complement, or other factors promoting phagocytosis. Phagocytic dysfunction leads to increased susceptibility to infections. Now let's know about chronic granulomatous disease, in short CGD. It is a fatal genetic disorder in which there is a deficiency of NADPH oxidase. In these patients, polymorphonuclear leukocytes, phagocytize invading bacteria normally but are unable to kill ingested microorganisms because engulfment of bacteria is not followed by activation by oxygen dependent killing mechanisms. The bacteria involved in the recurrent infections are catalyzed positive organisms such as Staphylococcus and coliforms. Catalase negative bacteria are handled normally. Leukocytes from these patients fail to reduce nitroblue tetrazolium during phagocytosis. This property has been used for the diagnosis of chronic granulomatous disease. And let's know about now myeloperoxidase deficiency. In this rare disease, leukocytes are deficient in myeloperoxidase. Patients are liable to develop recurrent Candida albicans infection. Now let's know about celiac Higashi syndrome. It is an autosomal recessive disorder. Polymorphonuclear leukocytes in these patients possess large lysosomes. These abnormal lysosomes do not fuse readily with phagosome. Thus, leukocytes possess diminished phagocytic activity. Patients suffer from severe pyogenic infections. Now, let's know about leukocyte G6PD deficiency. Leukocytes are deficient in glucose 6 phosphate dehydrogenase and so diminished bactericidal activity after phagocytosis. Such patients are vulnerable to microbial infections. Now let's know about secondary immunodeficiencies. These can occur secondary to a number of disease states such as metabolic disorders, malnutrition, malignancy, or as a consequence of certain therapeutic measures which depress the immune system. Secondary immunodeficiencies are more common than primary immunodeficiencies. Now, let's know about depression of humoral immune responses. This results when B cells are depleted as in lymphoid malignancy, particularly in chronic lymphatic leukemia, which when excessive loss of serum proteins occurs as in exfoliative skin disease and in protein losing enteropathies. In multiple myeloma, there is excessive production of abnormal immunoglobulins, but normal immunoglobulin levels is decreased. Now, let's know about depression of cell-mediated immunity. Cell-mediated immunity is depressed in acquired immunodeficiency syndrome, that is, in short, AIDS. Hodgkin's lymphoma, obstruction to lymph circulation, lepromatous leprosy, and some cases of sarcoidosis. Acquired immunodeficiency syndrome is the most important of secondary immunodeficiency disease. Finally finished. Any questions regarding this, you can ask me in the comment box and subscribe my channel for more updates. Thank you.